So we're going to be even smarter now by moving to the fourth lecture for this afternoon. I'm very privileged to have with us a pharmacist. She's a sole pharmacist in this room, so if there's any problems, she will be able to solve the problem for us. She's a pharmacist in Hospital Sultan Idris Shah, Serdang. She's Miss Chong Li Yin. She was in the two previous CPGs together with me. And if you don't already know her, you can actually watch her YouTube videos, right? So she will bring us through a title of a lecture, Patient Education, Self-Management Skills Training in Asthma. Li Yin.
Hello, everyone. My name is Lian. I'm pharmacist from Hospital Sultan Idris Shah, Serdang. Today, I will be discussing on the patient's education and skill training based on the CBG management of asthma in adult. Before we start, I would like to ask a question. How many of your poorly controlled asthma patients are due to not optimized treatment? Very often, actually, the issue is not the drug. It's because of patient misunderstanding, poor inhaler technique, or poor adherence. That's why, so today we are going to focus on how to fix that. By the end of these sections, we aim to understand the key component of effective patient education, skill training on effective use of inhaler device, explore strategy for improving patient adherence. The main goal of patient education is to provide patients and their families or other carers with suitable information and training on asthma management in partnership with their healthcare provider. Here, I would like to emphasize the word partnership because the asthma is not managed in the clinic actually. It's managed in the patient at home, at their work, or at school. We only see the patients every 3 to 6 months for 10 to 15 minutes. But the asthma patients, they live with the disease most of their life. The four components of patient educations are asthma information, guided self-management, skill training on effective inhaler use, and adherence improvement. Asthma information is an essential component of patient education. There were many times during my shift working at the ED pharmacy counter, I met patients with asthma exacerbations who didn't understand the need to getting followed up and getting an ICS started. Some would tell me that it's okay, whenever I have attack again, I just come back to the ED. Just like what I did today. It's quite sakit hati. It highlights that patient's education is essential. It's not optional. Inside the CBG, we have this checklist. That's the information that we should give to the patients, and they include patient information about asthma. What is this disease about? It's a chronic disease. The pharmacotherapy, there are differences between their blue inhaler and their chocolate inhaler. The non-pharmacotherapy, smoking cessations, and importance of adherence behavior. This checklist is readily available in the CBG. You can use them when you're giving education to your patients, so you won't miss any important information. You even can use this information, this checklist, to design an inpatient information leaflet to give to your patient. Guided self-management is an active process which involves a dynamic collaboration between patients and provider. Our role is to guide and support the patients by providing education, the tools for them that they know how to self-adjust the treatment at home and give them ongoing support. With that, the patient will develop self-management competency. They will gain skills and confidence to manage their disease independently. So you may ask me how to implement guided self-management. Asthma Action Plan, AAP, is the practical approach. Asthma Action Plan will guide the patient to self-monitor their symptoms or by PEFR if the patient has a prefill meter combined with regular medical review. And this has shown that it can reduce the ED visit and hospitalizations rate. Asthma Action Plan is a very effective tool. However, it still remains underutilized. It mainly due to two reasons. First, The design is usually unclear to the patients. Patients don't understand. Second, many healthcare providers unsure how to complete the asthma action plan. To address this, the CBG has designed the asthma action plan with separate column for reliever and controller, helping the patient better understand the difference between these two. And then for the yellow zone, the rescue doses already pre-filled. The dose already pre-filled according to the evidence and the practice. You may notice that the design of the AAP is not that colorful. It's intentional, in considering that some center may not able to print it in color printing. They have to print it in black and white. In the CBG, we have two templates to suit the different regime. First template is for separate inhaler for reliever and controller. And another one, the template for MAT therapy, maintenance and reliever therapy. I will use this scenario to explain on how to use the asthma action plan. This is in patients on PMDI salbutamol 2-puff PRN reliever and PMDI budesonide 2-puff PD controller. When patient in the green zone, patient is well, with all this no cough, wheezing, chest tightness, symptoms well controlled, patient have no need to use their blue inhaler, which is a reliever. But they have to continue using the controller, the brown PMDI, for example, as the dose that's prescribed. When the patient has to get some symptoms, which is in the yellow zone, as listed in the asthma action plan, patient can start to use reliever. The dose already pre-filled in the asthma action plan. Patient will advise to take 2 to 4 puffs every 20 minutes of their blue inhaler for a doctor 3 times and assess the symptoms. If symptoms of PEFR is improved, patient can lengthen the interval to every 3 to 4 hours as needed, and the duration may be further lengthened based on continued good response. But if symptoms is worsened or persist, proceed to the alert management. During the yellow zone, the AAP clearly states that the controller must be continued to be taken. In the alert zone, which is a dangerous zone, the patient has advised to proceed to the nearest hospital or clinic immediately, and during the transfer, the medication still can be continued with spacer. Increase the reliever dose up to 10 inhalation every 20 minutes. If patient without a spacer, take 2 inhalation every 5 minutes. Same controller need to be continued. How about for patients using MAT therapy? And asthma patients on budesonide formoterol, 1-puff PD and PRN, for example, when they are well, they have no need to use the reliever, except if before exercise is the one to use as a prophylactic dose. But they have to using their controller every day, even though the patients are feeling well. When the patient getting worse of their symptoms, don't wait. They advised to take 1 inhalation of their budesonide formoterol tubal inhaler as needed to a maximum 12 inhalation a day, including the controller dose. If symptoms are worsened or persist, proceed to alert management. In the alert management, the patient have to advised to proceed to the nearest hospital or clinic, and during the transfer, patient still can continue to take 1 inhalation every 1 to 3 minutes up to 8 inhalations. Skill training on effective inhaler use is another essential component for patient education. There are many types of inhaler available, and they can group into 3 categories, which is pressurized middle dose inhaler, for example, PMDI salbutamol, PMDI budesonide, PMDI Foster. Soft mist inhaler or Respimat, such as Spiriva Respimat, Spiotol Respimat. Dry powder inhaler, we have a lot. We have Sympicort tubal inhaler, Seretide acute inhaler, Foster next inhaler, Altipro breath inhaler, Anora ellipta, and Easy inhaler. All of these, each of them got their own advantage and disadvantage. So skill training is very important to reduce the inhaler errors. And these are the errors that have been associated with uncontrolled asthma. For example, PMDI, actuation before inhalations, incorrect preparation of the second dose, such as without proper shaking before the second dose, exhaling into the mouthpiece, or not holding the device upright. All these are associated with uncontrolled asthma. Dry powder inhaler. The main errors that link to uncontrolled asthma is insufficient inspiratory effort. The correct technique is that patient need to inhale strong and deep inhalations. Weak inhalation is linked to poor asthma control because it fails to generate the required inspiratory flow rate to deaggregate and inhale the powder effectively. So we must follow the principle of effective inhaler technique education to make sure the patient get the optimal dose from their inhalers. First, training of ourselves, training of the healthcare professionals. We all must know how to give correct instruction to the patient. Select the appropriate inhaler device for patients. Visual demonstration, not verbal. Teach to go. After visual demonstration, ask the patient to show us back the technique and then we correct accordingly. Then continuous monitoring and periodic reinforcement. I would advise to use algorithm when selecting an inhaler for patients. For example, this algorithm that I always use in my clinic is called ACT algorithm, Assess, Choose, and Train. The first part of this algorithm is to choose the inhaler based on the patient inhalation maneuver. After that, we check the patient ability to use the certain device. How to check the patient inhalation maneuver and decide on the inhaler type. So at this stage, you just ask the patient to perform 2 inhalation maneuver without using any device first. First, ask the patients to inhale slowly and deeply, then inhale forcefully and deeply. Then you may ask, what's the difference between these 2 inhalations? How slow is slow? I always use timing to guide my patients. Inhale slowly and deeply means inhaling over 3 to 5 seconds, just like this. If inhaling forcefully and deeply is inhaling 2 to 3 seconds, like this. That's the difference. After observe the patient, we ask the patient which inhalation maneuver the patient more comfortable. If the patient can inhale forcefully and deeply by observations and patient also think it's quite difficult to do it, then choose a PMDI or soft mist inhaler for the patient. If by observation you're still not unsure, these are the tools that you may use. These are injectile, the tubal halo whistle, and some feedback mechanism. Some inhaler come with feedback mechanism. After assessing the patient inhalation maneuver, we check the ability of the patient to use a particular device. You can show it yourself by visual demonstrations, or you can even use effective tools like video. Ministry of Health, in cooperation with Malaysia Thorax Society, have this inhaler video available in the YouTube. You can get the videos just by scanning the QR code. You can share these videos with your patients in the clinic. You can let them bring back, give them the QR code or the link so they can watch the video and learn the technique at home also. Inside the video, that features all these clear and complete info for the patients. The inhaler description, the parts of the inhaler introductions, how to check the dose balance, and the inhaler technique, and even cleaning of the inhaler. In the CBG, we also have this checklist, which is very useful for you when you are checking your patient inhaler technique in the clinic. By having this table, you can check is there any patient doing any step wrongly, mistakenly during your assessment. The next essential component of patient education is adherence improvement. Before we improve the patient non-adherence, we must assess the patient adherence pattern with proper tools. Patient-reported outcome instrument, PROS, or questionnaire are simple and timely, inexpensive tools that can be used in clinical practice. And the one already validated include this questionnaire called Thai questionnaire, Test of Adherence to Inhaler. It is available in English and also Bahasa Malaysia. This is the Thai questionnaire. It consists of 10 questions, and the full mark good adherence is 50 points. Yes, patient must get full marks to qualify as good adherence. But actually, the score is not the important thing that we should look at. By asking the patients to answer these questions, we can identify which part of the patient's non-adherence and what's the cause. Then we can tackle with strategies. And types of non-adherence can be categorized to 3 categories. Erratic non-adherence, which is caused by forgetfulness due to disorganized or very busy lifestyle. Unwitting non-adherence, patients who actually don't understand or unintentionally misapply the medication instructions. The last one is so-called intelligent non-adherence, but I don't think they are intelligent at all. It's patients intentionally not taking their medication as prescribed for reasons including the fear of side effects such as steroid and not feeling sick or high cost. Erratic non-adherence. Inside the CPG, we already list out the suggested improvement strategy that you can tackle the erratic non-adherence caused by forgetfulness and so on. So, for example, most of the patients will tell me that I always forget to take my morning ICS dose because I was too busy on the way to go to works and all that. So I would suggest them to link to daily habit to keep their ICS beside their bed. Once they wake up, they take their ICS first, then only go to brush their teeth because after using the ICS, memang they have to rinse and gargle the mouth. And then at night, before they brush their teeth and go to the bed, they take the inhaler again. So that's how we tackle the erratic non-adherence. How about for unwitting non-adherence? They don't take the medication actually because they don't know. There's a lack of education. This is the part that we need to educate them more. We simplify the regime. We give them asthma action plan so they get some guidance for them to follow. For the last, intelligent non-adherence. For example, I have this case on Monday. This patient, an engineer, so angrily telling me when I correct her inhaler technique, she told me, she said, since you say my inhaler technique is not good, how come I have been so well controlled all this while? But actually, she's admitted this time for exacerbations. This patient, you have to sit down calmly, explaining to her all about the disease and what's the indications of the medications and so on. So it's not easy, but we still have to do it. So who can provide the patient education? Not only pharmacists, everyone can do it, including all of you inside these virtual sections. Of course, pharmacy side, we have this program called Respiratory Medication Therapy Adherence Clinic, RMTAC, which is in collaboration with other healthcare providers. We provide educations, monitor the adherence, and resolving medication-related problems. And RMTAC have been proven can achieve better control asthma, and majority of the patient will be master good inhaler technique after this program. So take-home messages. Patient education consists of 4 components: asthma information, guided self-management, skill training, and adherence. Asthma information, that's the checklist that you can follow inside the CPG on the disease, medication, non-pharmacology, and importance of adherence. And guided self-management involves self-monitoring of symptoms with regular medical review, and of course, asthma action plan. Skill training, inhaler technique. Always check patient inhaler technique at every opportunity because this time the patient can master good inhaler technique. Once go home, come back, it will become worse again. So always check. Adherence, not easy to do it. Patient always say yes, I'm adhere, but they're not necessarily so because asthma when they're getting well, they don't appreciate the medications to take it every day. So that's all. That's end my sections. Thank you very much.
Okay, thank you, Lian. We can see you're very passionate. I'm sure a lot of patients have annoyed you along the way. I see a lot of thumbs up. Thank you very much.